You're all very welcome. Now, nosebleeds are very common at all ages, but especially at the extremes of life. Can I ask you here in the audience, how many here, if you put up your hands, have had nosebleeds in your lifetime? My gosh. But that would equate to the prevalence in the population. About 60% of people get nosebleeds at some time in their lives. Most of them resolve spontaneously. They're rarely life-threatening. The mortality rate from nosebleeds is extremely low. The two peaks of them are in children and old age people. While it's rare to die from a nosebleed, some famous people have died, and this gentleman here is Attila the Hun, a fierce warrior that died of a nosebleed on his wedding night. Now, there were contributory factors. He had taken a lot of alcohol during the day, and it wasn't his first wife. It was about his 8th honeymoon he was on. But he had a massive nosebleed during the night and succumbed to it. The Romanov family suffered from haemophilia. This was inherited through Queen Victoria, and the young boy here, Alexander, he had frequent severe nosebleeds. Unfortunately, as you know, the whole family were shot at the beginning of the Russian Revolution. Now, just to talk about the structure and function of the nose before we get on to nosebleeds. The nose is a fantastic organ. I don't think it's appreciated, really. If you look at this, is a CAT scan of the nose here. This is the orbit of the eye here. The brain is up here. These is the maxillary sinuses in the cheek. The nose is divided into two by a partition called the septum, and on the wall of the nose we have these swellings that are called terminates. And these are very important to the function of the nose. You can see on the scan that the nose is very close to the eye, a very little thin layer of bone that separates it from the orbit, and also very close to the brain. In fact, the nose is the only part of our body where the brain is actually exposed to the environment, because the olfactory nerve, which is attached to the brain, comes through the roof of the nose to pick up the chemicals for the sense of smell. The olfactory epithelium is actually now utilized to biopsy to diagnose early Alzheimer's disease. You can pick it up from biopsies of the upper part of the nose. And the olfactory epithelium is the only part of the brain that can regenerate itself. And studies are going on in this college and other colleges using olfactory epithelium as stem cells to replace damaged brain cells and nerve cells. This here is a side view of the sinuses here. These are the little honeycomb of cells separated by bone partitions or lamella. This is the brain up here. And again, you can see how thin the bone is that separates the roof of the sinuses from the brain. And these are the terminates here that we'll speak about in more detail. On this diagram here, you see the terminates, 3 of them. They're the functional units of the nose. Now, when we take a breath of air in from the front of our nose to the back of our nose, it takes about a millisecond for the air to pass. It's about 7 centimeters in length in an adult nose. By the time the air gets to the back of the nose, it's totally sterilized. It's humidified to 90%. Now, there's no machine devised by man that can replicate that. That allows for pure air to go down into your lungs. If you can't breathe through your nose, you breathe through your mouth, and your mouth can't humidify, filter, and sterilize air. At the back of the nose, we have the eustachian tube, which ventilates the middle ear. So the function of your nose is very important for the function of your ear. You've all suffered from a blocked sensation in your ears when you get off an airplane, or if you were snorkeling or diving. This is because the eustachian tube blocks off and you don't get enough air from your nose into your middle ear. For the nose to function, to do this fantastic work of humidifying and filtering air, it needs a very rich blood supply. This is the carotid artery that comes up from the heart. It divides it into 2 branches, the internal branch that goes up to the brain and supplies the internal brain, and an external branch that supplies the structures in our throat and neck. Now, the nose receives blood supply from both these vessels. It's the only structure in the head and neck that receives blood supply from the internal and external carotid artery, and there's cross circulation between the right and left. So the nose is one of the biggest blood supplies of any structure in the body. The blood passes through capillaries. You can see your own capillaries in your finger beds. The blood passes from the arterial side onto the venous side, and oxygen is taken out from the blood in the capillary bed here. Now, the nose is slightly different in that the capillary beds are much bigger in the nose than anywhere else in the body. There are huge venous lakes of blood just under the lining of the nose, and they're there for a purpose: to heat the air straight away to body temperature. So the nose is the only part of the body where blood vessels are so close to the surface. This is a high-powered microscope view of the lining of the turbinates. The turbinates have these little hair cells at the top of that pick up particles as they pass through, and bacteria. They waft back and forth like cilia. Or like seaweed. And underneath the surface you have these cells that produce mucus. The nose produces about 1 litre of mucus a day. People often come to the clinic saying there's a lot of mucus going down my throat, but we all produce 1 litre of mucus from our nose today to lubricate our throat. And just underneath the lining of the nose, where these cilia are, you have these big blood vessels or lakes. Now, in reality, they're only microns apart. So these blood vessels are very close to the surface of the air. And that's why we're prone to nosebleeds, because the biggest enemy of the nose is air, artificial air. In a hospital like Beaumont, where we work, we get an awful lot of older people coming in with nosebleeds in the winter months because they breathe in dry air. As you get older, you don't tolerate the cold for various reasons. You tend to sit beside radiators and heaters. This dries up the air. This causes the cilia to dry up and they fall off. And this exposes the vessels, which causes the bleeding. So dry air is the enemy of the nose. Our nose, unfortunately, because it takes millions of years to evolve, hasn't developed defense mechanisms against artificial air. We only have air conditioning and central heating around the last 100 years. 300 years ago, everybody was in cold environments, drafty houses. Now we all sit in dry rooms. So the nose has no protection against this. Now, when we get a cut in a blood vessel, this is a representation of a cut, the wall of the vessel contracts. It'll immediately to try and stem the flow. Cells called platelets clog up the opening, and a cascade of chemical events occur to form a fibrin-type material. It's like a sticky material, and a clot forms, and that stops the bleeding. That happens to us normally. Things that will interfere with that will be drugs, which we'll talk about in a minute. And this clotting or bleeding stopping mechanism occurs in about 5 minutes. A clot will take 5 minutes to form to block the bleeding. Now, this is a diagram of the nose here, and the two common sites of bleeding are at the front of the nose and at the back of the nose. Now, it's easy enough to deal with bleeding from the front of the nose because you can see and get at it easily, but bleeding from the back of the nose is much more difficult to deal with, and unfortunately in older people, most severe nosebleeds come from the back end of the nose. This area at the front is a common source of bleeding in children, as we'll see later on. This is just a diagram showing you the turbinates here with the instance of sites of bleeding. Here 4%, 12%, 8%. But 70% of nosebleeds occur from the partition or the wall that divides the nose into right and left cavities. Now, children commonly get nosebleeds, and the commonest reason is this. Self-trauma to the nose. Not to say that adults don't do that. If you're driving along in your car, just look out the window and you'll see how common that is. Now, treatment of nosebleeds in children is actually simple enough. You can just use an antiseptic cream. or even Vaseline ointment is enough, put inside their nose. That lubricates the nose and stops crusting, which prevents the bleeding. And if that doesn't work, we can cauterize the vessel quite easily because it's at the front of the nose. That's done in the clinic without sedation or anything like that. The majority of them, if you have a child who's getting frequent nosebleeds, just apply ointment to the inside of the nose about twice a day, and in 80% of cases the nosebleeds will stop, and tell them to keep their finger out of their nose, obviously. Nosebleeds in adults are a different scenario altogether. Obviously, systemic diseases have to be ruled in everybody with nosebleeds. And again, local trauma, inflammation. We all get a nosebleed, or you can get a nosebleed with a simple cold from the inflammation. Or people who have chronic allergies in the nose are more prone to nosebleeds. Foreign bodies would be rare in adults, but they do occur in children. But usually with the nosebleed, they have a foul discharge from the foreign body. Tumours are extremely rare, but they do occur and can present as nosebleeds. But a lot of the nosebleeds we see, we can't find a specific cause for. This is just a breakdown of the different causes of nosebleeds. And about 34% there, or 30%, you don't actually find a specific cause. Then there's all these causes here, like people with bleeding disorders, inherited bleeding disorders, as hemophilia, like the Romanovs. Hypertension is associated with nosebleeds, or high blood pressure, but it doesn't specifically cause a nosebleed. A lot of people who, at the age who get high blood pressure are prone to nosebleeds. But per se, the blood pressure itself does not cause the nosebleed. There are also myths about nosebleeds, just as Professor Williams was talking about strokes. A lot of people think they're going to get a stroke because they have a nosebleed. That's not true. Or that they have had a brain hemorrhage. That's not true. Other conditions that can present with nosebleeds are kidney failure and liver failure. Okay, so when we see an older person or an adult with a nosebleed, we have to think of the systemic cause and not just look at the nosebleed itself. Now, Professor Williams again was talking about the drugs that you use to prevent stroke, and somebody in the audience asked about aspirin. I'm sure there's a high percentage of people in this audience on aspirin. This drug Plavix here, and warfarin. Now, they all make people prone to nosebleeds, and a high percentage of the patients that come into our department with nosebleeds will be on these drugs. And it's a difficult management problem because it's risky to stop the drug, and yet they'll continue to bleed. So it's a difficult issue to deal with. Now, there's also people take over-the-counter homeopathic medications, and they can also interfere with coagulation. Some of them are listed here. I don't know if you can read them from the back, but fish oil, evening primrose, garlic, carberry juice, aloe, vitamin E, ginseng, St. John's wort, ginkgo biloba, valerian, ginger, kava, melatonin, ephedra. All of these things can predispose to a bleeding and nosebleeds. And if you're on aspirin, they'll compound the effect of aspirin or Plavix. So it's a thing we sometimes don't ask patients, are you taking over-the-counter medications? But we certainly will in future, because this has become a common reason why people are coming in with nosebleeds. Trauma from sports is obviously a cause, and nosebleeds from trauma can be life-threatening and severe. And of course, they can interfere with the ability of the player to function. Professional players, for example, boxers, can be stopped from boxing because of frequent nosebleeds, because of the fear of transmission of diseases. Now, there's sort of a pathway of care that you often hear about nosebleeds. Now, the first thing to do is to resuscitate the patient. Now, it's rarely that patients go into clinical shock from a nosebleed. You have to lose about at least 500 mils to get early signs of shock and a litre of blood before you go into absolute shock. So it'd be rare enough to lose that amount of blood from a common nosebleed. But first of all, you assess that they're not in shock, and then you have to try and find the nosebleed. You know, that's not always easy because there's blood pouring out at you, and it's a difficult management problem for a doctor as well. If you ask any ENT surgeon what they most hate doing, and they say it's dealing with nosebleeds, because they often come in late at night. The person is extremely anxious, obviously, and that causes their blood pressure to go off. So apart from resuscitating, the next thing is to allay their fears and even give them a sedative to try and relax them to get the blood pressure down. Then try and find the bleeding spot if you can. The best thing to do if you find the bleeding spot is to stop the bleeding directly. Now, if you have bleeding from your hand to your stomach, you can put pressure on it, but it's very hard to put pressure up your nose, and this is the problem. You can cauterize it or ligate the vessel, as we'll talk about later, and there's various options if these things fail, which we'll be talking about, embolization and surgery. But what usually happens is that the patient goes into a casualty department, and there may not be an ear, nose and throat service in the hospital, because a lot of casualties around the country don't have an ear, nose and throat, so a pack will be put into the nose and the bleeding point not identified. And that's a problem, because if the pack is removed and they're still bleeding, they've suffered from the trauma of the pack. And then they're referred up to an ear, nose and throat department maybe 24 hours later, and the problem is compounded by the pack having been in place. But the ideal sort of management thing is to identify the bleeding point, stop it directly by cautery or ligation, and only proceed to more advanced procedures if all this fails. Now, the primary treatment will only fail in about 6% of cases. If you get a nosebleed, the simplest way to stop it is using the Hippocratic method, described that long ago by Hippocrates, is to pinch the tip of your nose. That diagram here is showing that there. Not up here. People tend to want to pinch the top of their nose, but that's no good because the bone of the nose is up there. You're only pressing bone. The cartilage of the nose is the thing you want to press the lining of the nose against the septum. And what you do is you keep it pinched for 5 minutes. Why 5 minutes? Because that's the normal clotting time, as I showed you in the diagram. And it's also useful if you put a cube of ice in your mouth, because ice is cold and it causes the vessels to constrict. Some people also put a bit of ice on the neck. And what you should do is lean forward and spit out the blood if it's going down your throat, not swallow it, because the protein in blood makes you nauseous and can cause you to vomit. And you should stay bent forward like that for 5 minutes looking at your watch. And a high percentage of nosebleeds will stop with that simple Hippocratic method. When you eventually do end up having to come to the hospital, which about 14% of people with nosebleeds will do, there's a whole array of equipment we have available to try and deal with the nosebleed. The simplest one is the silver nitrate stick, which is a chemical applied to the bleeding point, which we do in children. A cautery machine to cauterize the vessel or solder it, and then various types of packs that we can put into the nose if all else fails. We also use local anesthetic. This helps putting in packs, and it also constricts the blood vessel. This is just a diagram of a silver nitrate stick being applied to this man who's having a nosebleed. Now, you can only do that when it's coming from the front end of the nose. You can't get those chemical sticks into the back end of the nose, okay? And that's a fairly atraumatic thing to do. Now, this is just a diagram of a nasal pack. Now, the traditional method was to pack the nose, both in front and behind the nose. This is a very traumatic thing to do. I don't know if any of you have had a pack in your nose, but it's a terrible sensation to have something put up your nose, and even worse to have it taken out. So we try and avoid putting these packs in anymore. If we can, sometimes you have to resort to it. Modern technology has improved our ability to deal with nosebleeds, that it has in every aspect of medicine. This is an example of a nasal tampon, which is a soft material you put into the nose, and then you squirt some water or saline on it, and it swells up, and it acts as a tamponade. It puts pressure on the bleeding point. So it's a packing that puts pressure on the point. You leave those in for about 24 hours, maximum 48 hours, and then you take them out. You can't leave them in too much longer because it gets secondary infection. The other option to tamponade the bleeding point is to put a balloon in. This is a balloon here. You squirt air or water into it, and that puts a pressure point on the bleeding point as well, and you can leave that in for 24 or 48 hours. That's just another example showing you how much pressure you can get into these balloons. Now, you just blow them up enough to stop the bleeding and not enough to cause too much pain or discomfort for the patient. And these are ideal for departments that don't have an ENT service available. The casualty doctors can put these in and then transfer the patient, if they have to, down to a department where there are ear, nose and throat doctors to deal with the problem. There are also agents that have come on the market which promote clotting. They're called hemostatic agents. There's a cascade of events that I showed you on the diagram. When you bleed, you get platelet adhesion, then you get fibrin, and you get thrombus or a clot. And these new agents act to promote the formation of thrombin. They're injected into the nose using a syringe. Now, the problem with these is they're quite expensive. Each one of these costs about 300 to 400 euros. So it's difficult for us in the hospitals to get them to buy these new materials. We're trying to do a study at the moment to show that they're cost effective, because if you can prevent the patient coming into hospital, that's a much cheaper option. This is just sort of guidelines for ear, nose and throat surgeons, basically saying that primary epistaxis and secondary epistaxis are different. And secondary epistaxis, where there's a cause, like liver failure, renal failure, drug reactions, are different, where you can't find the cause. The best treatment is to stop it directly if you can get to it. Indirect therapy, which is packing, should be avoided if you can help it. And then probably the best direct treatment is to surgically ligate the vessel, and I'll talk about that in a second. Now, endoscopic ligation of a vessel is where you put the patient asleep, or you can do it awake. This is a photograph here, and the surgeon uses a telescope looking into the nose, and he's watching it on a screen which is magnified. He's also got scans there to help the geography, because as you see, when you're in the nose, you're very close to the eye and you're close to the brain, so you have to be very careful with instruments or you can cause serious damage. And what we have now is actually image-guided systems that you use in your car to help you work your way around the inside of the nose. So using the screen, he finds the bleeding point, and now see, this is a surgery here looking into the nose, and this is the turbinate here being pushed out of the way. And this is to ligate a blood vessel. Now, studies have shown that if you do this directly, the person is in and out of hospital much quicker than if you go through the packing and all the other options. Just a delay here in the video, it'll move on. But this is opening up the little lamella or little bony ethmoid cells to get at the vessel. The orbit is just here, the brain is just up there. And you get to the vessel is back here. These are the little bony partitions that are being removed to get at the blood vessel. Just come along to the vessel here. It'll show up in a second. There's the blood vessel there. And what you do is you apply a clip to it. So the clip is being applied there, and that sort of seals off the vessel and stops it. Now, that might seem to be an invasive way of dealing with a nosebleed, but in fact, the risks of the surgery are very small, and it's much better for the patient in the sense that they're in and out of hospital much quicker than having a pack put on their nose and maybe kept in for 3 to 5 days before discharge. If surgery fails, you can embolize. And what embolize means is, now not every hospital can do this. There's only, Beaumont Hospital is the only one in the Republic that does this procedure. It's done for very severe nosebleeds in certain circumstances where people have abnormal blood vessels. This technique is also used for brain hemorrhages. And basically what this is done under an image guidance system. So the patient is lying here, radiologists here. There's done by radiologists, and they're looking at the image guide screen here, and they basically what they do is they put a catheter into the groin, which they bring up into the neck vessels, and they inject. This is the carotid here dividing into the vessels that go into the nose. This is the diagram here. So what they do is put a catheter right up in here, and they seal off the vessels by putting little coils into it, tiny coils. This is the technique that's used for treating brain aneurysms and bleeds in the brain. It can also be used for epistaxis. Now, in experienced hands, that's very effective, but you have to have a very experienced radiologist to do that, because if the coils go in the wrong place, it could cause a stroke. There are certain hereditary conditions that contribute to nosebleeds. This is one of them here. These little blood vessels on the tongue and on the lips and skin are called telangiectasia. This is a hereditary condition that affects men and women. And the commonest presentation these people get is a very debilitating condition. They get recurring severe nosebleeds, and their hemoglobin drops from a normal of 12 down to 4. It can totally destroy their lives. It's also a life-threatening condition because they can have these telangiectasia vessels in their brain, so they can get brain hemorrhages. They can be in the lung and in the liver, and it's very important for the females in the family to be screened for that, because they can have massive hemorrhages during pregnancy. The treatment for epistaxis in patients with this hereditary condition is very, very difficult, because their blood vessels all over their body are abnormal. They have no elastic in the blood vessel, so the vessel doesn't constrict at all, so they bleed very easily. And there's a whole lot of operations for these patients. And when you see any condition that requires a lot of options of operations, it usually means most of them don't work. And basically what we do in these patients now is to avoid trauma to their nose. That's the worst thing you can do, is pack them. What we do is use these hemostatic agents that I showed there, which cause no trauma to the nose. And if all else fails, what we do is actually we close off the nose. We actually stop air going up the nose altogether, because, as I said, the air is the enemy of the nose. So they can't breathe through their nose, but their nosebleeds stop. Regarding the costs are very important in healthcare. As you know, we spend about 10 billion a year on health in this country. You could question how well is it spent. In our sort of specialty, ear, nose and throat, over 40% of our admissions are due to nosebleeds, and the majority of those patients will stay in 5 days. Our aim is to try and stop people being admitted to hospital, not to stop them, but to treat them as outpatients by using a flow chart of, as I outlined, of avoiding packing, going directly to stopping the vessel. And we did a study in our hospital recently, and just in our department alone, nearly $250,000 was spent on managing nosebleeds. So if we could save $250,000 in every hospital, we'll be contributing a lot to the health service. So I'll finish up with that. Thanks very much. The purpose of this talk today was to explain to the public about nosebleeds and how common they are. They occur at all ages, but mainly in children and older people. The biggest enemy of the nose is the atmospheric air we breathe, dry air from central heating and air conditioning. And I was explaining to the audience that it's very important that they moisten the air they breathe at night, especially in bedrooms, using humidifiers, and to use simple techniques like salty nasal sprays to keep the nose lubricated. Nosebleeds are common, they're rarely life-threatening, but they can be a great nuisance. With modern technology now, we have various means of stopping them, avoiding putting major packs into their nose, using endoscopic techniques to seal the blood vessels. And the cost of nosebleeds to the economy is very significant, and the aim of our future management is to try and prevent patients being admitted to hospital with nosebleeds and treat them as outpatients.
I attended the RCSI MiniMed lectures a couple of times. I've been very informative. The information is portrayed in a good way. for all aspects, from layperson up to a professor or consultant in medicine, and I'll continue to attend these over the next couple of months as I find them very informative and help me in my daily life, in my work and my healthy lifestyle.